The diagnostic criteria for obstructive sleep apnea is largely based on research conducted in men, leading to a limited understanding of how the condition presents in women. Unlike men who typically exhibit loud snoring and noticeable breathing pauses, women often experience more subtle and atypical symptoms. Because these symptoms do not fit the classic obstructive sleep apnea profile, many women go undiagnosed or are misdiagnosed with conditions like depression, anxiety, or chronic fatigue syndrome. This diagnostic gap has led to delays in treatment and an underestimation of the true prevalence of sleep disordered breathing in women. Hormonal changes play a significant role in obstructive sleep apnea risk for women. Before menopause, estrogen and progesterone provide some protective effects on the upper airway muscles, reducing the likelihood of collapse. However, after menopause, the decline in these hormones weakens airway stability, increasing the prevalence of obstructive sleep apnea in women. Additionally, women often experience less severe and shorter apneas when compared to men, meaning their apnea-hypopnea index, or AHI, may fall below the traditional diagnostic threshold, despite experiencing significant daytime impairment. Researchers are emphasizing the importance of subjective symptoms of obstructive sleep apnea, such as daytime sleepiness, cognitive impairment, and mood disturbances, which can be more pronounced in women even when their apnea-hypopnea index is relatively low. Another sleep disordered breathing condition that disproportionately affects women is upper airway resistance syndrome, or UARS. While UARS does not always lead to the same severe oxygen desaturation as obstructive sleep apnea, it still causes chronic sleep fragmentation and increased respiratory effort, preventing deep restorative sleep. This can result in excessive daytime sleepiness, cognitive dysfunction, and mood instability. Because UARS does not always meet traditional obstructive sleep apnea diagnostic criteria, many women with this condition are again misdiagnosed with chronic fatigue syndrome, fibromyalgia, or generalized anxiety, rather than a sleep-related breathing disorder. Over time, the cumulative effect of poor sleep due to a condition like upper airway resistance syndrome can lead to a wide range of health problems, from chronic fatigue to cognitive dysfunction to cardiovascular issues, all of which can significantly impact an individual's quality of life.
Women with obstructive sleep apnea often report symptoms like insomnia and daytime fatigue as their primary complaints, rather than the classic signs of loud snoring and gasping. Women frequently experience difficulty staying asleep due to frequent awakenings from upper airway resistance. In addition to sleep disturbances, women with obstructive sleep apnea may also experience cognitive dysfunction, such as memory problems, brain fog, and difficulty concentrating. They often feel tired even after a full night of sleep, a symptom that can be easily overlooked. Mood disorders, including depression and anxiety, are more common in women with obstructive sleep apnea, likely due to the negative effects of poor sleep on brain function and emotional regulation. Hormonal fluctuations, particularly during perimenopause and postmenopause, can exacerbate these mood disturbances. Women with obstructive sleep apnea may also snore, but their snoring tends to be less loud and frequent when compared to men, which can make the condition harder to detect. Additionally, women have less severe and shorter apneas that may not cause significant oxygen drops, making diagnosis more challenging using traditional measures like the apnea-hypopnea index, or the AHI.
Other symptoms, such as morning headaches and dry mouth due to mouth breathing, are more common in women and are often dismissed as unrelated to sleep apnea. Gastroesophageal reflux disease, or GERD, which is also more prevalent in women with obstructive sleep apnea, can further complicate the diagnosis, as symptoms like heartburn may be attributed to gastrointestinal issues rather than an underlying sleep disorder.
Hormonal changes, such as those experienced during menstruation, pregnancy, and perimenopause, also influence the presentation of obstructive sleep apnea in women. For example, pregnancy-related hormonal shifts can cause nasal congestion and upper airway swelling, worsening sleep apnea symptoms. And after menopause, the decline in estrogen levels can weaken the muscles around the upper airway, increasing susceptibility to OSA. Recognizing these differences in symptom presentation and diagnostic challenges is critical for improving detection and treatment of sleep-disordered breathing in women. A more comprehensive approach that considers subjective symptoms, sleep quality, and upper airway resistance, rather than relying solely on AHI or the apnea-hypopnea index, is necessary to ensure that more women receive appropriate diagnosis and treatment.
Clinically, children with obstructive sleep apnea will frequently present with habitual snoring, often with intermittent pauses, snorts, or gasps during their sleep, as well as bedwetting, night sweats, restless sleep with frequent awakenings, irritability, and behavioral issues, especially those analogous with ADHD symptoms, including an attention deficit, impulsivity, aggression, and hyperactivity.
Unlike adults whose diagnosis heavily relies on higher apnea-hypopnea index thresholds, pediatric sleep apnea is diagnosed at much lower thresholds. Since untreated, pediatric sleep apnea can lead to behavioral problems, learning difficulties, including poor academic performance, and long-term cardiovascular complications. Early diagnosis and intervention are essential to improving outcomes.
The most important takeaway here is that all children and adolescents should be screened for snoring, especially if behavioral issues are reported by their parents. As per the American Academy of Sleep Medicine, in the presence of snoring, a referral to pediatric ENT is appropriate to assess for adenotonsillectomy need, as this is recommended as the first-line treatment for patients with large tonsils.